When you push off a wall, maybe swing a tennis racket, or even just pick up your morning cup of tea, you're actually relying on a joint that handles incredible forces, sometimes up to 20 times greater than the load you're holding,
Mm,
your elbow. But it's really far from being just a simple hinge, isn't it? It's more like this incredibly complex piece of biological engineering.
it really is, surprisingly so.
Welcome to the deep dive. Today, we're going to unpack a really fascinating collection of source material. We've got academic papers, some clinical notes, research findings, all focused very intently on the elbow. Its surprising intricacies, the anatomy, how it moves, what goes wrong when it breaks,
Hmm.
how clinicians diagnose the problems, how they fix them surgically, and then that long journey back to function. And guiding us through all this, helping connect the dots on this, well, often underestimated joint, is someone who really knows how to distill complex information into those essential insights. It's great to have you with us.
It's a real pleasure to be here exploring this rich material with you.
So our mission today is really to get beyond that surface level view, to properly appreciate the elbow as this engineering marvel, understand the common issues, but also the complex ones it faces, and really grasp how they're managed, drawing directly from the perspectives laid out in these sources we've got.
Sounds like a good plan.
Right, let's dive straight in then. Perhaps a few rapid-fire questions just to set the scene.
Sure.
You described the elbow as an engineering marvel. If you had to pick one single surprising fact about its structure from these sources, what would it be?
I think for me, it's the fact that it isn't just one joint. It's effectively three distinct joints, all functioning together within a single shared capsule.
Three.
Yes, you got a hinge, a sort of ball and socket, and a pivot joint, all working in concert.
Three in one. Okay, well, that immediately changes how you think about it, doesn't it?
It does.
And think about the forces it handles. You mentioned that 20 times multiplier. Where does that become particularly relevant from a clinical standpoint, according to the sources?
I'd say recovering from a significant fracture, perhaps something like the olecranon, that's the pointy bone at the back of your elbow.
Right.
Because the triceps muscle pulls so incredibly hard on that point during extension. Getting that bone to heal securely under all that tension, it's absolutely paramount. The forces involved are just enormous.
That really paints a picture. And lastly, just quickly, this material covers everything from, microscopic anatomy right through to complex surgery. What's one major challenge that clinicians seem to consistently face when treating these complex elbow problems based on what we've read?
I think it comes down to the inherent conflict between achieving stability, making the joint secure, and regaining motion, getting it moving again.
Ah.
Often, treating one of those things can actually make the other worse, particularly in difficult cases where you've got complex instability alongside stiffness. It's a real balancing act.
Stability versus motion, that sounds like a fundamental tightrope walk for surgeons and therapists.
It really can be.
Let's unpack that first part then, the stability and there's incredible forces, by diving a bit deeper into the elbow's engineered complexity. We started by calling it intricate engineering. Can you elaborate a bit on how those three joints you mentioned, the hinge, the ball and socket, the pivot, how are they actually structured together?
Absolutely. So the sources describe the elbow joint primarily as the meeting point between the lower end of the humerus, your upper arm bone, and the upper ends of the radius and ulna in your forearm.
Okay.
The main hinge part, the bit that does most of the bending and straightening, is the humeral ulnar joint. That's where the sort of C-shaped trochlea on the humerus fits snugly into the trochlear notch of the ulna.
Like a well-fitted hinge.
Exactly.
Yeah.
Then you have the radiocapitellar joint. That's where the rounded end of the humerus, the capitellum, meets the shallow cup on the top of the radius bone. This acts a bit more like a ball and socket, allowing the radius to rotate against the humerus.
Right, for twisting movements.
Precisely. And that leads to the third joint, the proximal radial-ulnar joint. This is where the head of the radius pivots within a notch on the ulna, held in place by the annular ligament. This is the pure pivot joint that allows pronation and supination, that twisting motion of your forearm when you turn your palm up or down.
And all three are inside one capsule.
Yes, all enclosed within that single articular capsule. It's quite an efficient design.
It sounds like the actual shape of the bones themselves must provide quite a lot of inherent stability to start with.
They really do. Especially that humeral ulnar joint. The deep fit of the ulna onto the humerus, particularly the coronoid process at the front and the olecranon at the back, acting like bookends, provides significant intrinsic stability. It really limits forward and backward movement. The sources also mention a slight forward tilt or anteversion of the distal humerus, which contributes to this inherent stability as well.
The bones alone can't do it all, can they? The ligaments must be absolutely crucial.
Oh, absolutely critical. The sources reference O'Driscoll's really important work from 2000, which classifies the elbow stabilizers quite clearly.
Okay.
The primary stabilizers are described as the key ligament complexes, the medial collateral ligament, or MCL, on the inside of the elbow, and the lateral collateral ligament complex, the LCL, on the outside. These are the main passive restraints, like strong guide ropes.
Main guide ropes. And then there's secondary ones too, and dynamic ones.
Correct. The secondary stabilizers include the radial head itself, the joint capsule, both the front and back parts, and also the bulk of the flexor and extensor muscles that cross the joint.
So the radial head plays a role too.
Yes, it's particularly important as a secondary block against valgus stress that's force pushing the forearm outwards,
Yeah.
especially if the MCL is injured.
I see. And the dynamic ones.
The dynamic stabilizers are the muscles that actively contract across the joint. They provide stability through their tone and their action. Think of the biceps, the brachialis underneath it, the triceps at the back, and the smaller anconeus muscle. It's this layered system you see, static ligaments and dynamic muscles working together, that allows the joint to function under quite significant loads.
That makes me think about people who put huge forces through their elbows repeatedly, pitchers, tennis players, weightlifters. How do these stabilizers actually cope with that? And how does the biomechanics explain those massive forces, that 20 times multiplier you mentioned earlier?
Well, let's think about active extension, like throwing a ball or pushing something away forcefully.
Yeah.
The main muscle doing the work is the triceps, particularly its medial head, with some help from the anconeus.
Okay.
Now, if you're just straightening your arm without any external load, most of the weight-bearing stress goes through the main humeral-ulnar hinge joint, with less on the radiocapitellar joint.
But as soon as you add resistance.
Exactly. That's where the forces really escalate dramatically. The sources highlight that these forces increase significantly when you have to co-contract your forearm muscles, perhaps for gripping something tightly or stabilizing your wrist at the same time.
Right.
And interestingly, the biceps muscle also gets involved during forceful extension, providing a stabilizing counterforce estimated at around 7% of the triceps tension.
So even the muscle on the other side is working hard.
Yes, to control and stabilize the movement.
And that 20x force multiplier, where exactly does that figure come from?
That's primarily down to the mechanical disadvantage the triceps works at. When you extend your elbow from a bent position, the triceps tendon has to wrap around the olecranon and the back of the humerus, the trochlea.
Okay.
This means it pulls very close to the joint's axis of rotation. It has a very short moment arm. The source actually estimates this moment arm is only about 2 centimeters long, very small. So to overcome this leverage disadvantage and generate powerful extension against a load held in your hand, the triceps muscle itself has to generate forces that are roughly 20 times greater than that load you're handling.
20 times. That's just astonishing, isn't it? It really puts into perspective why injuries involving the triceps tendon or where it attaches to the olecranon must be so problematic.
Exactly that. And the source really stresses the critical clinical importance here. It explains why achieving really secure fixation of the olecranon after fractures or after procedures like an osteotomy where the bone is cut is absolutely vital. You need that bone to be able to withstand these massive tensile forces during the healing and rehabilitation phase. And it also explains why preserving bone stock, particularly the olecranon, is considered mandatory during procedures like total elbow replacement. You simply have to have a solid anchor point for the implant and the muscle forces.
To really understand this level of precision and the forces involved, the sources delve quite deeply into biomechanical modeling. Now, this sounds incredibly complex, trying to capture all this intricate movement and force mathematically.
It is very sophisticated work, yes.
Yeah.
The source discusses approaches like the International Society of Biomechanics, ISB recommendations from 2005, which built on earlier work. The core idea is to use coordinate systems.
Okay.
You define a joint coordinate system, or JCS, to describe the relative movement between the bones. And this JCS is defined using bone-embedded coordinate systems, or BEFs, which are essentially reference frames fixed to anatomical landmarks on each bone, the humerus, the radius, the ulna.
So it's a bit like putting virtual markers on the bones and tracking how they move relative to each other.
In essence, yes. You describe the kinematics, the motion itself, by looking at the relative orientation of these bone frames over time. Often a mathematical process called Euler decomposition is used to break down the complex 3D movements into sequences of simpler rotations around defined axes.
Right.
However, a key challenge that the sources point out very clearly is that the axes you define for these BEFs, based on external anatomical landmarks you can feel or see on imaging, are often just approximations of the true functional joint rotation axis. Those true axes are embedded within the bones and the cartilage surfaces themselves.
Ah, so you're essentially trying to model the real internal movement using axes that are estimated from the outside.
Precisely. And that introduces potential inaccuracies. The Thoris explores different ways these BEFs can be defined on the humerus and the forearm bone.
Mm-hmm.
But what's particularly insightful, based on their simulation results comparing different models, is that only one specific model, discussed referred to as the HWRFWJCS model, was capable of exactly reproducing the imposed kinematics they tested it with.
And what made that particular model different? Why was it more accurate?
It's unique because it doesn't just rely on approximating the axis from external landmarks. It actually embeds knowledge about the true functional axes of flexion extension and pronation supination within its mathematical structure.
So it has the inside knowledge built in.
In a way, yes. This higher level of detail reflecting the actual joint mechanics is necessary for true accuracy. When they simulated movements using the different models, they found that while the estimates for the range of flexion extension were fairly consistent, maybe only a 3–4% error range across the models.
Okay, that sounds reasonable.
There were much greater differences in how the models represented other aspects, particularly the carrying angle and the patterns of pronation supination.
The carrying angle. That's the slight outward angle your forearm makes when your arm is straight down by your side, palm facing forward.
That's the one. It's typically defined as the angle between the long axis of the humerus and the long axis of the forearm in that extended supinated position. The source references a standard definition and notes that some models stick closely to this,
Right.
but others show different carrying angles simply because of how they define the forearm's long axis within their model. It depends on the chosen landmarks.
So the definition affects the measurement.
Exactly.
Yeah.
But here's the really key point from the biomechanics perspective, particularly when using that more accurate HWR-FW model. The carrying angle it calculates isn't really seen as a degree of freedom, something that just changes freely with movement.
Yeah.
Instead, it's interpreted as a measure of the intrinsic model parameters, or, putting it anatomically, it's seen as a reflection of the internal morphology of the joint itself.
So it's telling you about the fixed structure, the shape of the bones, and how they fit together rather than just the way the arm happens to be positioned at that moment.
Precisely. It reflects the inherent geometric relationship between the main flexion-extension axis and the pronation-supination axis, which is fundamentally built into the shape of your bones and the joint surfaces.
That's quite a conceptual shift.
It is, and it raises a fundamental question about how well different biomechanical models actually capture these crucial, fixed structural properties of the joint, not just the gross external movements we can observe. It really underscores the depth of analysis required to truly understand how this joint functions, especially under load.
It's absolutely fascinating to think about the elbow at that level of biomechanical detail, almost like reverse engineering it. But of course, when a patient walks into the clinic with a problem, you can't just put them in a sophisticated motion capture lab straight away.
No, definitely not.
You need to figure out what's actually going wrong inside. So let's pivot now to how clinicians actually assess elbow problems in practice. After hearing the patient's story, what are the key steps in the physical examination?
Well, the clinical examination really is the cornerstone. The sources describe a very meticulous process of palpation that's carefully feeling around the joint.
Right.
You'd be feeling for specific bony landmarks, like the radial head. You can feel that rotating as you turn the patient's forearm while bending and straightening their elbow. Or identifying tenderness over the olecranon bursa, a common site of inflammation.
Mm-hmm.
Finding the distal biceps tendon is crucial, especially if you suspect a rupture. And the sources warn you have to be careful not to confuse it with the lacertus fibrosus, which is a fibrous band nearby. That's a common pitfall. A more elusive structure to palpate, but important in certain nerve issues like PN compression, is the arcade of Froese. That's described as being roughly 2 centimeters in front of and 3 centimeters below the lateral epicondyle. It's where the posterior interosseous nerve dives into the supinator muscle.
So quite specific anatomical knowledge is needed just for palpation.
Absolutely. And then there are the specific physical tests. The sources mention quite a few for different suspected conditions.
What are some examples?
Well, for cubital tunnel syndrome, where the ulnar nerve is compressed at the elbow, the Tinel sign tapping over the nerve to see if it reproduces symptoms is commonly used. The elbow flexion test, holding the elbow fully bent for a minute or so, is also highly recommended in the source material.
Okay.
And critically, the source stresses always testing for ulnar nerve instability. You can sometimes actually feel the nerve flicking or subluxating out of its groove as the patient bends and straightens their elbow.
Ah, right. And for things like tennis elbow.
For lateral epicondylitis, or tennis elbow, the Cozen test is described. The patient makes a fist, straightens and pronates their wrist, and then resists the examiner pushing down while the examiner feels the lateral epicondyle. Pain or noticeable weakness, there's a positive sign, especially if it's worse, with the elbow held straight.
Makes sense. What about testing for the kind of instability we were talking about earlier, the joint feeling loose or giving way?
There are specific tests for that too.
Uh,
There's the stand-up test, sometimes called the chair sign. The patient tries to push themselves up out of a chair using the affected arm.
okay.
If the elbow is unstable, this combination putting weight through the arm, compression, turning the palm up, supination, and a natural valgus stress can cause apprehension, a feeling that the elbow is about to go, or even a noticeable subluxation. The source notes it's quite a sensitive test, which is useful clinically. There's also the posterolateral rotatory drawer test. Here, the examiner gently applies force to the radius and ulna, with the elbow bent at 90 degrees, again looking for that feeling of apprehension or instability. And of course, there are the standard valgus and varus stress tests, applying sideways force to check the integrity of the MCL and LCL respectively. Often, these are best done under fluoroscopy using live X-ray, so you can actually see how much the joint gaps open.
So a combination of feeling, specific maneuvers, and sometimes imaging during the test itself.
Exactly, building up a picture.
Beyond the physical exam, how do clinicians actually quantify the patient's function or track the outcome of a treatment? Are there specific scoring systems used?
Yes, the sources discuss several commonly used assessment scores. The Male Elbow Performance Score, or MEPS, is mentioned frequently. It looks at pain, overall function, and the range of motion just for flexion and extension.
Okay.
It's relatively easy to use, but it does have limitations. It doesn't assess strength or the crucial forearm rotation range, and pain accounts for quite a large percentage of the final score.
So perhaps it doesn't give the full picture, especially for more complex problems.
That's a fair point. The Liverpool Elbow Score, the LES, is presented in one source as a potentially higher quality instrument. It combines a clinical assessment by the examiner, including range of motion, strength, and ulnar nerve status, with a patient questionnaire focusing on their pain and function in daily life.
That sounds more comprehensive.
It does. It's noted as being particularly useful for tracking outcomes after total elbow replacement. And the patient answered section means it can even be used for mail-in follow-ups, which is practical.
Mm-hmm.
The Hospital for Special Surgery, or HSS score, is also mentioned. That's a 100-point system incorporating pain, general function, the full range of motion including both flexion extension and pronation supination, and importantly, it includes an assessment of strength, often using weighted tests.
So it seems there are different scores tailored for slightly different purposes or levels of detail.
Precisely. Clinicians would choose the most appropriate one for the situation.
And of course, alongside the physical exam and scoring, imaging is absolutely crucial for seeing the exact nature and extent of the injury, isn't it?
Oh, absolutely pivotal. As the sources clearly describe, the technology here has evolved significantly over the years, moving from basic analog X-rays to highly advanced digital modalities.
Right.
Multi-detector CT, or MDCT, is highlighted as being particularly valuable in cases of acute trauma. It provides incredibly high-resolution images and allows for multiplanar reconstruction, MPR, and 3D reconstructions. This helps surgeons really visualize complex fracture patterns and dislocations much more clearly than with plain X-rays alone.
And presumably helps with planning surgery.
Immensely. The sources also make a point of noting that although modern CT scanners acquire many more images, technological advances mean this is often achieved with reduced overall radiation exposure compared to older scanners, which is obviously important.
That's good to know. And MRI, where does that fit in?
MRI is considered really key for assessing many musculoskeletal conditions around the elbow. Its capabilities have also improved dramatically with technological developments like new imaging sequences and better surface coils.
Mm-hmm.
It's particularly good for visualizing soft tissues, ligaments, tendons, cartilage. And it's also very helpful for detecting nerve issues, as it can show changes in the muscle supplied by an injured nerve, what's called denervation signal.
So CT for bone detail and trauma, MRI for soft tissues and nerves. Is it that simple?
It's often used that way, but the sources actually provide a very useful flowchart that guides the choice of imaging based on the timing of the injury. suggesting a more nuanced
Oh,
approach.
that sounds helpful. What does it suggest?
In the very acute phase, say less than 24 hours after injury, it's typically X-ray first, perhaps followed by CT if the fracture looks complex or involves a dislocation. One pager specifically notes the importance of identifying sublime tubercle fractures on CT, linking back to that coronoid instability we discussed. In the early subacute phase, maybe 5 to 7 days later, X-ray, ultrasound, US, and potentially MRI might be used.
Yeah.
MRI at this stage could show things like muscular edema or swelling around a nerve.
Hmm.
In the late subacute phase, perhaps after 3 weeks, X-ray, US, CT, and MRI all have roles. CT might assess bone healing, while MRI could start to show muscle atrophy if a nerve injury isn't recovering. And for chronic, long-standing issues, pretty much all modalities might be considered, potentially including CT or MR arthrography, where contrast dye is injected into the joint to better visualize things like cartilage damage or tears in the joint capsule.
You mentioned ultrasound US again there. What's its specific advantage when imaging the elbow? It seems to pop up at various stages.
Its main advantage, and it's a significant one, is that it's dynamic. You can actually see the structures moving in real time as the patient moves their elbow or contracts muscles.
Oh.
This makes it excellent for evaluating things like fluid collections, joint effusions, or bursitis. It can measure tendon thickness, which might indicate adaptation or pathology. It can detect acute changes in tendons after intense activity. And it's particularly valuable for evaluating the ligaments dynamically, like the radial and ulnar collateral ligaments, assessing their integrity under stress.
And tendon tears.
The source notes that dynamic US performed while the patient contracts the relevant muscle is often better than a static MRI for identifying tendon tears. And perhaps surprisingly to some, it's often considered superior to MRI for evaluating nerve compression syndromes around the elbow.
Superior to MRI for nerve compression. That's quite a statement.
It is. It really underscores the fact that each imaging modality has its unique strengths and weaknesses. You need to choose the right tool for the specific question you're asking.
Absolutely. Even going back to basic x-rays, the sources emphasize the need for expertise there too, don't they? Getting the positioning right.
Definitely. Specific views are needed, like the medial oblique view to properly visualize the trochlea and the proximal ulna, including the olecranon and coronoid, or an AP view taken with the elbow bent to 45 degrees. The sources mention the practical difficulty positioning a painful, swollen elbow correctly for these views can be challenging, and poor alignment can easily distort the image in high pathology.
And interpreting x-rays in children with all the growth plates must add another layer of complexity.
Oh, absolutely. You need to have a thorough knowledge of the predictable sequence in which the various ossification centers appear around the elbow, the capitulum first, then the radial head, medial epicondyle, trochlea, and finally the lateral epicondyle.
Right.
Comparing the injured side to the healthy uninjured side is standard practice to help spot subtle deviations or fractures involving these centers. But a crucial warning from the sources is that in the early stages of conditions like osteochondritis dissecans or OCD, where there's damage to the cartilage and underlying bone, the x-rays can actually look completely normal because the damage is mainly in the non-ossified cartilage.
So a normal x-ray doesn't rule everything out in kids.
Not at all. Radiographic signs of OCD, like radiolucency or sclerosis in the bone, tend to appear later. And you also have to be careful not to misinterpret normal physiological appearances, like a slightly different angulation of the lateral condyle ossification center in very young patients, as a fracture. Experience is key.
This whole journey through assessment and imaging really highlights the detective work that's involved before any treatment plan can even be formulated, doesn't it?
It absolutely does.
It's a blend of skilled hands-on examination, carefully listening to the patient's symptoms, and then knowing precisely which imaging tool, sometimes even dynamic ultrasound, will reveal the crucial details needed to make the right diagnosis. For professionals listening, I think it really reinforces the value of mastering those fundamental assessment skills and understanding the specific strengths and limitations of different technologies.
Well said. That detailed understanding is the foundation for everything that follows.
Right. So, armed with that detailed picture from the assessment and imaging, clinicians then face those crucial decisions about treatment, especially when bones are broken or ligaments are torn. And this material really highlights that these aren't always simple, straightforward choices.
No, they certainly are not, and the sources really emphasize the complexity involved, particularly in severe injuries. Take something called complex elbow instability, or CEI. That's defined as a situation where you have both stiffness and instability coexisting in the same elbow.
A difficult combination.
Extremely difficult because, as we touched on earlier, treating one can easily aggravate the other. The core surgical goal, described in the sources for CEI, is to restore the primary and secondary stabilizers sufficiently to achieve stability, which then allows for early controlled rehabilitation to address the stiffness.
And what might that involve surgically?
It can be quite extensive. It might involve an arthrolysis to release the stiff tissues, possibly replacing the radial head if it's fractured beyond repair, maybe reconstructing the coronoid process or the collateral ligaments using grafts, and sometimes even using an external fixator temporarily to hold everything in place while the soft tissues heal.
You mentioned reconstructing the coronoid process there. The sources seem to place a huge emphasis on the importance of even small coronoid fractures, particularly referencing O'Driscoll's work.
They absolutely did. O'Driscoll and colleagues' classification from 2003, which was based on CT assessment, really changed how these fractures were viewed. They classified them based on their location. Fractures of the tip are type 1, fractures of the anteromedial facet are type 2, and fractures involving the base are type 3.
Okay.
The really critical insight that came out of this work, and is heavily emphasized in the sources, is that even untreated small type 2 fractures, those involving the anteromedial facet, are incredibly important.
Why are those small ones so significant? They sound like they might be easily missed.
They can be, but they are often associated with an injury to the lateral collateral ligament complex. And when you have both that small AMF fracture and an LCL injury, it can lead to a specific and problematic pattern of instability called varus posteromedial instability.
Okay.
Essentially, the intact AMF is key to resisting varus force pushing the elbow inwards. If it's fractured and unstable, the elbow tends to hinge open on the lateral side, leading to increased loading and stress on the medial side of the joint, the humeroulnar articulation. And the source warns this abnormal loading pattern can lead to premature arthritis down the line.
Wow.
Specific subtypes of type 2 fractures, particularly those involving the sublime tubercle, where a key part of the MCL attaches, are highlighted as being particularly crucial in this posteromedial instability pattern. It's a perfect example of how understanding the biomechanical significance of a seemingly small bony detail can have a massive impact on the whole joint's long-term health and the surgical strategy needed.
That level of precise classification and understanding how these small fragments affect the overall stability is really quite eye-opening, isn't it?
It really is. It changed practice.
So, how are these really complex injuries, like the so-called terrible triad involving elbow dislocation with associated radial head and coronoid fractures, typically approached surgically?
Well, the overarching aims are consistent. Restore stability to allow for that crucial early rehabilitation. A posterior surgical incision is very common, as it provides good access to most parts of the joint.
Right, the backdoor approach.
Exactly. If the radial head is fractured, it's typically exposed via the Kocher interval, which is an approach on the lateral side. Interestingly, accessing the radial head this way often widens the associated LCL injury, making its repair necessary and perhaps slightly easier. The coronoid fracture needs to be fixed too. Simple sutures passed through bone tunnels might be used for small tip fractures, type 1, while larger fixable fragments might get K-wires or small screws. Sometimes this can even be done through the same lateral approach used for the radial head. The absolute key is reestablishing that stable bony and ligamentous framework so the elbow can start moving.
Beyond these complex instability patterns, dealing with fractures that primarily involve the joint surface itself, like those coronal shear fractures of the capitellum or trochlea, must also be incredibly challenging for surgeons.
They certainly are. They're described as relatively uncommon, maybe 6% of distal humerus fractures overall, but the sources note their incidence seems to be increasing, particularly in older women, perhaps due to osteoporosis.
And how do they typically happen?
The usual mechanism is a fall onto an outstretched hand, but with the elbow partially bent and the forearm pronated, palm down. This drives the radial head upwards and backwards into the capitellum, shearing off a fragment of the joint surface. They can also happen sometimes when a dislocated elbow is reduced.
And are they often isolated injuries?
Frequently not. The sources highlight a strong association with radial head fractures occurring together in up to 30% of cases, and also with LCL lesions, found in up to 40%. So, ligament disruption and associated dislocation are common companions to these shear fractures.
So imaging must be critical again here.
Absolutely. Plain X-rays often underestimate the true extent of the damage, particularly any associated comminution fragmentation at the back or involvement of the trochlea immediately. A good quality CT scan, preferably with 2D and 3D reconstructions, is usually recommended for accurate diagnosis and surgical planning.
And the treatment is usually surgical fixation.
Yes, open reduction and internal fixation, or AF, is generally preferred, aiming to restore that smooth articular surface as perfectly as possible. If there's significant comminution at the back, supplemental fixation with small plates or even bone grafts might be needed.
Hmm.
And crucially, the source stresses that LCL repair is mandatory whenever you're fixing these fractures because of that high association with ligament injury.
What if the fragments are too small or damaged to fix?
Excision or removal of the capital fragment is generally avoided unless it's tiny and truly unfixable, precisely because of the high risk of causing instability.
Hmm.
For non-repairable fractures, the options become more salvage-oriented, including things like capitular prostheses, partial humeral hemiarthroplasty, or even total elbow arthroplasty in selected cases. The source also makes an interesting point that even small impacted fragments at the back of the capitellum can contribute to ongoing radiocapitular instability if not addressed.
It sounds incredibly complex. And distal humerus fractures, DHF in general, those involving the lower end of the upper arm bone, are described as demanding procedures even without these specific shear patterns.
They remain very demanding, yes. The primary goals are always achieving an anatomical reduction of the joint surface, getting the pieces back together perfectly, and then achieving stable fixation, ideally with compression across the fracture lines. The source mentions various plating techniques used to achieve this. A really key point emphasized is the importance of maximizing the accuracy and success of the first surgical attempt. Salvage options for complications like malunion, healing in the wrong position, non-union, not healing at all, or vascular necrosis, bone death due to loss of blood supply, are often limited and have poorer outcomes. Stable fixation is what allows for that vital early range of motion, which is critical for preventing stiffness later on.
Is the approach different for these distal humerus fractures when they occur in elderly patients?
This is highlighted as a significant point of ongoing debate in the sources. Historically, ORIF was considered the gold standard for most patients, but some of the literature cited shows quite variable outcomes for ORF in patients over 65. Issues like hardware failure, loosening, and problems with union can be more common in weaker osteoporotic bone.
So what's the alternative?
Primary total elbow arthroplasty, replacing the joint straight away rather than trying to fix the fracture, is increasingly considered and discussed as a viable option, particularly for lower demand elderly patients who have very complex fracture patterns or significantly poor bone quality where fixation is unlikely to hold reliably. It's a complex decision-making process, balancing the risks and potential benefits of complex reconstructive surgery versus joint replacement.
Shifting focus slightly to pediatric injuries, lateral condyle fractures in children seem particularly problematic because of the growth plates involved.
They are very problematic, and a common pitfall is underestimating their severity based on x-rays alone, because so much of a child's elbow is still cartilage and doesn't show up well. Untreated or inadequately treated fractures here can lead to significant long-term disability. The potential complications listed are quite serious. Malunion leading to stiffness, or non-union when the fragment fails to heal, which can cause a cubitus valgus deformity. The elbow angles outwards more than normal. This deformity, in turn, can eventually stretch and trap the ulnar nerve years later, causing what's called tardy ulnar nerve palsy.
Wow, years later.
Yes. Other complications include outright elbow instability if non-union occurs, and even a vascular necrosis, loss of blood supply to the fractured fragment, which can sometimes be caused by the initial injury or inadvertently by the surgical dissection needed to fix it.
The source mentions different classifications being used for these childhood fractures.
Yes, classifications based on the degree of angulation and displacement of the fragment are used to guide treatment decisions. There seems to be some debate highlighted about whether fractures with relatively small amounts of angulation, perhaps less than 30 degrees according to some authors, can be managed conservatively without surgery. Fractures with greater angulation usually require reduction, attempting to manipulate the fragment back into place. But the source also notes a concern that the surgical trauma involved in attempting reduction for these more significantly displaced fractures could potentially have a negative impact on the final outcome itself. It's another tricky balance.
And what about that fishtail deformity mentioned? That sounds quite unusual.
It's described as a rare long-term complication, specifically of these lateral condylar growth plate fractures. It's thought to be caused by premature closure of the central part of the growth plate, possibly due to the initial injury or maybe related to osteonecrosis of the trochlea.
So the middle stops growing, but the sides keep going.
Exactly. The medial and lateral parts of the growth plate continue to grow normally, creating this characteristic inverted U or V shape on X-ray, resembling a fishtail. This abnormal shape can then impinge on the ulna during movement and significantly reduce the elbow's range of motion.
Goodness. So we've seen how precise diagnosis leads to these really intricate surgical decisions and techniques. How do surgeons physically get access to these complex areas? The source mentioned the universal posterior approach quite prominently.
Yes, the posterior approach is often considered the workhorse or universal approach because, as O'Driscoll is famously quoted in the source, the front door to the elbow is at the back.
Ah, okay.
It provides excellent exposure to the posterior aspect of the joint, obviously, but also allows good access to the lateral and medial sides, and if needed, it can be extended proximally or distally to access the anterior compartment as well. Patient positioning varies. Some surgeons prefer the patient lying on their side, lateral decubitus, while the authors of one section prefer the patient supine with the arm draped across the chest. Pneumatic tourniquets are pretty standard to control bleeding.
And within that main posterior approach, there seem to be different techniques specifically for how the triceps muscle is handled.
That's correct. The sources discuss the pros and cons. There's the triceps-on technique, where the surgeon works around the triceps attachment to the olecranon, leaving it intact. Studies cited, particularly in the context of total elbow arthroplasty, suggest this approach can lead to good outcomes with potentially fewer complications like triceps rupture, and maybe allow for faster rehabilitation and better range of motion compared to techniques that involve detaching the triceps tendon,
So keeping it attached is often preferred.
which seems to be gaining favor. For fixing distal humerus fractures specifically, a triceps-sparing modification of the posterior approach is also mentioned, again with the aim of facilitating faster rehab and improving the final range of motion for the patient.
Are there any other key surgical approaches mentioned for specific situations?
Yes, the Kocher approach, which is made on the lateral side of the elbow, is described as essential, particularly when dealing with radial head fractures or lateral collateral ligament injuries, as it allows complete exposure of the LCL complex. As mentioned before, it's often used in conjunction with a posterior approach for terrible triad injuries.
Right.
The source actually lists around 9 different approaches specifically for distal humerus fractures alone, ranging from performing an olecranon osteotomy, cutting the olecranon bone itself for access, to various muscle splitting or muscle reflecting techniques like the TR-AP approach or the Brian-Morey approach. The choice really depends heavily on the surgeon's experience, the specific fracture pattern they're dealing with, and any associated injuries.
And protecting nerves must be paramount during these exposures.
Absolute critical. Nerve isolation is described as mandatory in almost all these approaches. Particularly, meticulous identification and protection of the ulnar nerve posteriorly is essential, as it runs right through the operative field in many cases. Similarly, the posterior interosseous nerve, PIN, needs careful identification and protection during lateral approaches, especially around the radial head and neck.
Once the surgeon is in and the fractured bones are put back together, how is everything held in place? What sorts of fixation methods are described?
A whole variety of implants are used, tailored to the specific bone and fracture type. For smaller fragments like parts of the coronoid or the capitellum, cannulated screws or simple K-wires might be sufficient. Osteosuture, using strong sutures passed through bone tunnels, is mentioned specifically for fixing the coronoid tip. For radial head fractures, small screws or mini plates might be used if the fracture is suitable for fixation, generally meaning fewer than 3 fragments. For the larger distal humerus fractures, pre-contoured locking plates are commonly used now. Locking screws provide better fixation in osteoporotic bone or highly comminuted fractures. The source also notes that plates with a slim profile and polished surface are often preferred to try and limit soft tissue irritation under the skin.
And what about those complex radial F fractures that just can't be pieced back together reliably? Is removing the radial head still an option, or is replacement the standard now?
That's another area where practice has evolved, according to the sources. Historically, if a radial head fracture was isolated, meaning no other major ligament injury or fracture, displaced, and very comminuted, radial head resection, simply removing the broken pieces, was considered an option. But the sources mention significant controversy surrounding this now. Several studies cited reported a surprisingly high prevalence of radiographic arthritis developing in the elbow joint in the years following radial head resection. So, while it might provide initial pain relief, the long-term consequences on joint health are a concern.
So if just removing it isn't ideal for the long term, what's the main alternative?
Radial head replacement using a metal prosthesis. This is generally indicated when internal fixation isn't deemed reliable, for example, too many small fragments, poor bone quality, or when excision is considered too risky because it would leave the elbow unstable, particularly in the context of associated ligament injuries or coronoid fractures.
Right.
Bipolar designs, where the prosthetic head can articulate slightly within the stem, are mentioned as having reported success in some studies.
And selecting the right size prosthesis seems incredibly important based on the sources. It's clearly not just a case of grabbing one off the shelf that looks about right.
Absolutely not. The sources are very explicit about this, citing several biomechanical and clinical studies. Selecting the prosthesis with the correct diameter and height is described as paramount for achieving a successful outcome.
What happens if the diameter is wrong?
If the diameter is too large, it doesn't fit properly into the sigmoid notch of the ulna and can overload the edges. If it's too small, you get abnormal point loading in the center of the notch. An incorrect diameter can also cause a cam effect during forearm rotation, basically. Abnormal mechanical interaction, which can lead to pain, stiffness, and abnormal loading on the capitulum of the humerus.
And the height. Getting that right must be just as critical.
Just as critical, yes. If the prosthesis sits too high, making the radius effectively too long, it overstuffs the joint. This typically leads to stiffness, particularly loss of extension, and often causes persistent lateral elbow pain due to increased pressure in the radiocapitellar joint.
And if it's too short?
If it's too short, the elbow may remain unstable, particularly if there were associated ligament injuries. Surgeons use the excised bone fragments as a template, compare them to trial implants, and often use anatomical landmarks, like the proximal edge of the lesser sigmoid notch on the ulna, as a guide to restore the correct length. They'll check the motion carefully after inserting the definitive implant to ensure it's congruent and moves smoothly without catching or feeling too tight or too loose. And crucially, the lateral collateral ligament complex must be repaired or reconstructed after radial head replacement to ensure the necessary stability. It's a really complex procedure requiring significant surgical judgment and precision.
This whole overview of injury management really drives home the point that treating these complex elbow problems is anything but routine or straightforward, doesn't it?
Not at all.
It requires that incredibly precise diagnosis, often drawing on detailed classification systems like O'Driscoll's for the coronoid, and then executing these intricate surgical plans that have to be tailored very specifically to the injury pattern and the individual patient's needs and bone quality. It really is a testament to the necessary blend of deep anatomical knowledge, sophisticated biomechanical understanding, and advanced surgical skill.
Couldn't agree more.
Yeah.
It's multifaceted.
So we've explored the incredible engineering, the detailed diagnostics, and the often intricate repair work involved with the elbow. But the final step, and often the longest part of the journey, is actually getting that engineered joint functioning properly again. Let's talk about rehabilitation. Maybe we can cover this in a slightly quicker format, perhaps looking at some surprising aspects or key instructions that stand out from these sources. What's one overarching principle of elbow rehab that comes through consistently?
I'd say it's the principle of early mobilization. The sources consistently highlight its benefits whenever feasible, improving blood flow, helping to reduce swelling through that squeezing effect of movement, and generally speeding up the recovery of range of motion. Getting things moving early safely is key.
Right. And thinking about specific instructions, what's one piece of advice given to patients that is absolutely critical after they've had a total elbow prosthesis fitted?
This one is really key and probably surprising to many patients. It's emphasized for the long-term survival of the implant. The patient must not lift more than 2 kilograms with that arm, ever.
Just 2 kilograms for life.
For life. That's roughly the weight of a standard bag of sugar, or perhaps a full kettle. This limit is presented as pretty much non-negotiable to protect the implant from loosening or excessive wear over time.
Wow, that puts the functional capabilities or perhaps limitations of a replaced elbow joint into very sharp perspective, doesn't it?
It certainly does. It's a critical constraint that patients need to understand and adhere to for the maintenance, as the source puts it, of their prosthesis.
Speaking of regaining motion, which is often a huge challenge after elbow injury or surgery, how do the sources suggest addressing that, especially getting back those last difficult degrees of flexion or extension.
The concept of low-load prolonged stretching comes up frequently. The sources suggest this approach, applying a gentle, sustained stretch over a longer period, is often preferred over things like static progressive splints, which patients sometimes struggle with compliance or find irritating.
So gentle and sustained is the key.
Yes, the idea is to encourage gradual lengthening of the tight, soft tissues without causing excessive pain or reaction.
What about hydrotherapy doing rehab exercises in a swimming pool? Is that seen as beneficial?
Yes, it gets a positive mention, particularly exercising in warm water over 30 degrees Celsius. The warmth itself can help reduce pain receptor firing and relax muscles.
Hmm.
And the buoyancy of the water reduces the load and shear forces on the joint, provides support, and allows for progressive muscular work starting at a very low intensity. The sources suggest it might be possible to start pool-based exercises even a couple of weeks earlier than equivalent exercises on dry land, sometimes as early as the second post-operative day if waterproof bandages are used.
That's quite early. We touched on epicondylitis or tennis elbow earlier. The rehabilitation section for that mentioned, perhaps surprisingly, a lack of strong scientific evidence for many commonly used therapeutic methods. How do clinicians navigate that uncertainty according to the sources?
It really reinforces the need for a highly individualized treatment approach. It needs to be based on the specific patient's presentation, their functional demands, and, frankly, the clinician's own experience and judgment. While some techniques, like specific manual therapies or manipulations, might show some short to midterm benefits in certain studies cited, the sources generally suggest that robust long-term evidence favoring one specific approach over another or even over doing nothing is often lacking.
Yeah.
One author cited even felt corticosteroids shouldn't play a major role. This really makes customization and clinical reasoning absolutely vital.
So it's less about following a rigid protocol and more about skilled assessment and tailoring.
Precisely.
And stiffness, or joint contracture, is obviously a common and difficult problem after elbow trauma. How is the rehab approach tailored for that?
Stiffness is often managed initially with surgical release or arthrolysis to physically break down the scar tissue.
Right.
But this absolutely must be followed immediately by structured, often intensive rehabilitation to maintain the motion gained in surgery and prevent the stiffness from recurring.
Right, you have to keep it moving.
Exactly. Heterotopic ossification, which is abnormal bone forming in the soft tissues around the joint, is mentioned as a major extrinsic cause of contracture. Treating established HO typically requires a combination of surgical excision, sometimes postoperative prophylaxis like radiation or medication to prevent recurrence, and that crucial early structured rehab program.
Hmm.
Bracing is also used here, both static and dynamic types, to try and maintain the motion gained.
Are there any specific points mentioned about rehabilitation after nerve surgery around the elbow?
Yes, following procedures like nerve revision or grafting for late post-traumatic neuropathies, there's typically a period of immobilization, maybe around a month, to allow the nerve repair to heal. After that, gradual mobilization begins, first passive, then active.
Hmm.
Patient compliance with the rehab exercises is noted as being fundamental for success, and biofeedback techniques are mentioned as being potentially useful tools to help patients regain awareness and control of the reinnervated muscles.
Finally, just quickly, any thoughts from the sources on other physical therapies beyond manual techniques or exercise? Things like therapeutic ultrasound or shockwave therapy.
They get a mention. The sources suggest that low-intensity pulsed ultrasound, LIOPUS, and extracorporeal shockwave therapy, ESWT, are being researched and used for various conditions, including tendon pathologies and promoting bone healing. The proposed mechanisms involve stimulating cellular responses related to tissue regeneration and remodeling. However, like with epicondylitis treatments, the level and consistency of high-quality evidence is still evolving for some applications. It's presented more as an area of ongoing research and potential adjuncts rather than established primary treatments for all conditions.
This lightning round on rehab really gives a fascinating glimpse into the sheer variety of approaches and considerations needed to restore function after dealing with the complex issues we've discussed. It's clearly not a one-size-fits-all process.
Not at all.
From those fundamental principles like early motion through to very specific constraints like that strict 2 kilogram lifetime lifting limit for prostheses, to the challenges of managing stiffness or navigating therapies where the scientific evidence is perhaps still developing, it really underscores that rehabilitation is a highly tailored, often lengthy, and collaborative process.
It absolutely is. It relies heavily, as the sources imply, on excellent communication between the surgeon, the physiotherapist, and crucially, the patient. And it requires constantly adapting protocols and interventions based on the individual's specific injury, their surgical outcome, and how their recovery is progressing over time.
Wow. Well, we've certainly covered a huge amount of ground today. We've journeyed through the elbow from its incredible three-joint architecture and the almost unbelievable 20x forces it has to endure through the meticulous detective work involved in assessment and choosing the right imaging. Then into the intricate world of surgical repairs with their specific classifications, ongoing debates, and precision requirements. And finally, we've landed in the multifaceted, long-term journey of rehabilitation.
Indeed. I think the sources collectively paint a vivid picture of the elbow as this true marvel of biological engineering. And successfully managing its problems, particularly the complex ones, really demands a deep integrated understanding. That
Yes.
means understanding everything from the foundational biomechanics and detailed anatomy to recognizing the subtle nuances of specific injury patterns, appreciating the capabilities and limitations of different imaging modalities, knowing the technical precision required in surgery, and perhaps most importantly, understanding the critical role of carefully tailored, often challenging, and prolonged rehabilitation.
So if you had to pull out a few key takeaways from all this material.
I'd say the absolutely crucial nature of the collateral ligaments and the coronoid process for maintaining elbow stability, the sheer magnitude of the forces at play during active extension, and what that means for fixation, the surprising value of specific imaging techniques like dynamic ultrasound for nerve assessment, the importance of detailed classifications like O'Driscoll's for the coronoid in guiding surgical strategy, the existence of ongoing debates and evolving approaches for managing complex fractures, especially in specific groups like the elderly. And finally, the paramount importance of patient understanding and adherence to rehabilitation guidelines, particularly something as strict as that lifetime weight limit after elbow replacement.
It really underscores that developing expertise in any professional field isn't just about knowing the basic facts, is it? It's about truly understanding the intricate details, appreciating how different components are interconnected, like how one tiny bone fragment can destabilize the entire joint. It's about being able to weigh conflicting evidence or different potential approaches, and then applying all that knowledge effectively to complex, often unique, real-world situations. It really is problem solving at a very high level.
Absolutely. And perhaps we take one final step back and consider the historical perspective. This material touches upon, pioneering work done decades ago by figures like Rizzoli mentioned in some texts, the constant evolution of our understanding driven by better modeling and imaging techniques, and these ongoing debates about the best way to manage certain conditions or the true evidence base for various therapies. What is this whole continuous process of refinement, reclassification, and sometimes disagreement? Tell us about the fundamental nature of knowledge and expertise, particularly in complex, high-stakes fields like medicine.
That's a fascinating question. Perhaps it suggests that absolute certainty is always somewhat provisional, and that true expertise requires not just knowledge, but also a comfort with navigating ambiguity and uncertainty.
I think that's a very insightful way to put it. It really highlights that while rigorous scientific evidence is absolutely vital and something we must always strive for in many complex clinical situations, particularly with challenging patients, the human element, the experienced professional's judgment, their ability to synthesize all the available information, weigh the nuances, and adapt the approach to the unique individual sitting in front of them remains absolutely fundamental. There's always more to learn, always more to refine, and sometimes the evidence alone just isn't enough.
That's a really powerful thought to conclude on the enduring importance of skilled human judgment alongside the science. If you found this deep dive valuable and thought-provoking, please do consider rating and sharing the show on LinkedIn or X so other professionals can discover it too. Thank you so much for joining us today on this exploration of the elbow's incredible complexity, and thank you especially for guiding us so expertly through these dense but fascinating sources.
It's been my pleasure entirely. A fascinating joint indeed.
Join us next time for another deep dive.